Hi, everyone. Welcome to Philosophy, Disability, and Social Change, Session 4. My name is Laura Couples, and I'm an instructor at Gonzaga University. My research falls at the intersection of science and values, health policy, and the epistemology of disability. And I'm pleased to be chairing today's session. Our speaker today is Joseph Stramondo, and he'll be presenting his paper, Vulnerability to COVID-19 and the Moral Perniciousness of Congregate Care. This session is closed captioned if you click on the icon at the bottom of your screen, and questions for our speaker can be posted to the Q&A below. They'll be addressed at the end of the session. Joseph Stramondo is an assistant professor of philosophy and associate director of the Institute for Ethics and Public Affairs at San Diego State University. His interests focus primarily on the intersection of disability, or rather philosophy of disability, and bioethics. More specifically, he has written more than 20 scholarly articles and book chapters on topics ranging from informed consent procedures to reproductive ethics to assistive neurotechnology. His current research is devoted to developing 2 book manuscripts. The first is under contract with Routledge and will address the ways in which the field of bioethics fails to address the moral salience of the social categories of gender, race, disability, and sexuality. The second will offer a systematic, limited defense of the permissibility of using reproductive technology to choose to have a disabled child. If you're ready, Joe, I'll cede the floor to you.
Great, thank you for the introduction, Laura. I just want to start by saying thank you to Laura, but also to our conference organizers, Jonathan Wolf and Shelley Tremaine, for putting together a absolutely incredible 3 days. I'm very honored to have been asked to be part of this, and hopefully I won't let you all down. Okay, so my talk in some ways, I hope, is complementary to what we heard from Shelley Tremaine yesterday. It is sort of a slightly different take on an analysis of institutional long-term care and COVID-19, and sort of how the various risks of contracting COVID-19 have been amplified by institutional long-term care and the systemic ableism that's embedded in those structures. So let me advance my slides here. My main claim is going to be that mainstream bioethics hasn't done a very good job with understanding what social obligations we have to recipients of institutional long-term care during the COVID-19 pandemic, because it hasn't done an adequate job of analyzing what our responsibilities are to these folks in general. And so to understand the duties that we have to folks within the system of institutional long-term care, I argue that we must reconceptualize the meaning of both vulnerability and institutionalization. And so this is ultimately a kind of concept analysis. I argue that both of these concepts would be better equipped to think through what we owe folks in institutional long-term care if we reframed them as a matter of power. And so in the case of vulnerability, we want to define it in terms of power as well as physiology. And in terms of institutionalization as a concept, we want to define that in terms of power rather than location or segregation or some of these other definitions of what it means to be institutionalized. And so hopefully this will become more clear as things unfold. So what we've seen so far during the pandemic is attempts to protect people from COVID-19 in institutional settings with interventions like more staffing, better staff training and infection control practices, better enforcement of infection control protocols, PPE, personal protection equipment, and rapid testing. And so that has been sort of what's been going on since March. And as Dr. Tremaine really laid out nicely yesterday for us all, it hasn't worked, right? The numbers, the data show us that there is still a lot of COVID-19 running rampant in the institutional long-term care system, and a lot of people are getting sick, and a lot of people are dying. And so this isn't working sort of as a practical intervention, and it's certainly not working as a moral intervention. We're not doing what we ought to by helping folks in the institutional long-term care system when it comes to COVID. And so I think that the reason why bioethics hasn't really done a very good job of taking this up and dealing with it, in addition to some of the metaphysical claims that Shelley was defending yesterday, I think that we need to look at the concepts of vulnerability and of institutionalization, okay? And so standard duties to protect folks in institutional care too narrowly define vulnerability, okay? So in other words, vulnerability has been framed as a physiological or biological phenomenon. And in reality, it is at least also a power and political issue, okay? And so, yes, perhaps the virus does affect different people with different bodies differently, but focusing only on this explanation of what makes someone vulnerable to poor health outcomes obscures the ways in which power also plays a role. And so here I am just sort of rehashing a little bit of what Shelley talked about yesterday. And I'm going to quote one of her blogs at length here to drive this point home. And then we'll talk about the definitions of institutionalization. So deaths, this is Shelley, deaths have been cast as tragic consequences of the unique circumstances that surround the virus itself, attributed to its specific features and etiology, the speed and efficiency with which it circulates, and lack of epistemic authority about it, rather than contributed to and regarded as a consequence of the very nature and functioning of the nursing homes in which deaths have occurred. Seniors and elders in nursing homes and elsewhere aren't inherently vulnerable, nor are disabled people in institutions inherently vulnerable. Both of these groups, among others, are rendered vulnerable. That is, they are made vulnerable. And so what I'm interested in is unpacking exactly how people that are living in institutional settings are made vulnerable, okay? So when we talk about vulnerability, in this sense, we're talking about a power disparity, okay? And so this isn't a new concept, right? In that this is true for health disparities in general that track race, income, gender, and so on. There's lots of evidence of the ways in which power makes people more vulnerable to poor health outcomes, right? But what we need to do is apply the same thinking to disability and long-term care systems, okay? And so we need an analysis of how power disparities embedded in the long-term care system have made people vulnerable specifically to COVID-19. And so that's sort of what I'm going to be talking about for the remainder of our time. Sorry, excuse me. So typically institutions are defined both in public policy, but also is sort of in the public imagination in terms of three factors: either their physical size, their numerical size, or whether or not they are segregated rather than integrated, okay? And so physical size just means the literal size of the building, the physical size of the dwelling in which people are housed. And so in an attempt to deinstitutionalize, some institutions have used cottages rather than dormitories. And so you have sort of these smaller buildings that you move people into all on an institutional campus and say, oh, institutionalization is over now. In contrast, we also have numerical size that's sometimes used to define what an institution is. And so here, it's the number of residents living together in a single dwelling or on a single campus. And so here we see sort of the move toward group homes with smaller numbers of people living together as an alternative, supposedly, to an institution. And then finally, the other access that we can try to understand institutions based on, traditionally anyway, is this idea of segregation. In other words, whether or not disabled and non-disabled people live together in an institution, in an integrated neighborhood or apartment building, or if folks are segregated into groups according to the presence of disability or not. Okay, so that's how institutions are typically defined, and I'm arguing that this concept of an institution is inadequate for understanding the moral character of an institution and what we owe people that are living in institutions. Instead, I argue that institutions ought to be understood in terms of power disparities. Okay, so according to this view, an institution is any place a disabled person lives in which they do not have control over the care or support they receive. Okay, so it's purely defined in terms of power rather than location or number or segregation. And so what follows from this definition is that there can in fact be what's sometimes referred to as an institution of one. And this is a situation in which someone lives in a single person dwelling in a integrated neighborhood or apartment, but lacks any kind of meaningful control of their care. Okay, and so what I mean when I say meaningful control of their care is a lack of power to determine things like what care they receive, where care is received, when care is received, and I think most crucially, who provides that care. Okay, and so um, to unpack this a little bit more, what care to receive includes, decisions about whether or not you need help with certain things. In particular, maybe certain, behaviors that we sometimes hear about in institutional settings where people are trying to discourage certain behaviors in a disabled person, right? That's sometimes framed as a kind of care. Where care is received. In other words, where do you live? Do you have control over that? When it is received, this is a big one, right? Do you have control over when you bathe or when you take your meals? And finally, who provides that care? Now, who I want to talk about in a little bit more depth because I think it's actually the most important of these factors. And that's for two reasons. One reason is that many of the activities of daily living that someone gets help with when they are using the long-term care system um, require a certain level of intimacy. And so things like bathrooming, bathing, and so on. And so not having control over who is doing these things with you and for you, I think is a really morally problematic thing. Okay. One ought to be able to have control over who is taking such a role in one's life. The second reason why who is incredibly crucial when talking about the control that someone has over their care is because power over what, where, and when, in many times, flows from power over who. And what I mean by this is that if the disabled person receiving care has the power to hire or fire a caregiver, then they have implicit control over these other features of care as well, right? Nobody's going to tell you when you have to go to bed or when you have to take your meal if you have the power to fire them from helping you, right? And so the who question, I think, is sort of the linchpin here. And so one of my good friends, Cal Montgomery, helped me think through a lot of these issues. He does some incredible work with his blog, and so you ought to Google him and read more about some of this. And he pointed me toward the question of the burrito test. Okay, and so the burrito test just asks, can someone wake up in the middle of the night at midnight and microwave their own burrito just because they feel like it and they're hungry, right? If someone is living in a setting in which they can't do that, then it's very, very likely that we ought to consider that setting as an institution, because it shows that they don't have meaningful control of their care, okay? So we can also think through community-based care via these kinds of power relationships, okay? Community-directed care, or sometimes it's referred to as consumer-directed care, sorry, is care in which a disabled person has the power to determine the what, where, when, and who questions, okay? And so what's interesting about this is that, and what I'm sort of arguing for, is that this understanding of what constitutes an institution versus a setting in the community, as far as the long-term care system goes, really is quite separate from questions of segregation, numerical size, and the size of the building, right? Because we can imagine a situation in which community-based care can exist in a large building that is mostly segregated and that includes numerous disabled people all living in this same place, and still be community-based care, so long as the appropriate power relationships exist, according to this definition, okay? And so an example of something that would meet this set of criteria and still be community-based care, we can imagine a college dormitory where multiple disabled students have self-segregated, right? They've chosen where to live and who to live with, and they share personal care attendants as they direct their own care, okay? And this isn't a purely hypothetical example of what I would call community-based care, even though it's happening in a large building with a largely segregated group of disabled people that are, multiple. Okay, and the reason why I know that this isn't a purely hypothetical example is because this is how I experienced grad school, where I lived in a accessible dormitory where lots of us chair users got together and set up a little community of disabled folks and sort of had a really wonderful situation of interdependence where we were helping each other and also sharing resources in terms of personal attendance. Okay. And this was certainly not an institution because of the kind of power relations that existed. Okay, so there are several challenges that might be leveled toward my definitions of institutionalization and community-based long-term care. Okay, the first challenge might be what we call the challenge of capacity. And so the challenge of capacity might say something along the lines of, well, not all disabled people have the capacity to exert power over the who, what, where, and when of their care. And so for those disabled people, this view of what constitutes an institution versus a community-based system would place them in an institutional setting almost by definition, right? And so I think that there are some responses to this that go a long way toward relieving this worry. Um, First, I think that when people level this worry, they underestimate um, the capacity that a lot of people have for agency. I think that agency is much broader, even for people with the most serious disabilities, serious in scare quotes, right? Than is even often assumed. I think that, and this is something that I actually learned, not as a scholar, but as an activist, when I was working um, for the protection and advocacy system within the United States, and going into the state institutions in Texas and monitoring them for neglect and abuse. I saw that a lot can be learned about the preferences that people have, about where they live, what care they get, when they receive care, and especially the who questions of care, even for someone who is nonverbal. Okay. And so our approach to deinstitutionalization of care should not be about deciding in proxy for someone about the nature of that care, but rather ensuring that the agency that someone has and that they can express is recognized and respected. And so I think this goes a long way toward dissolving this challenge of capacity. You can tell whether or not someone wants to be cared for by another particular individual, right? And whether or not they like the person doing the caregiving, or whether they'd prefer to have someone else, right? And again, the who question, I think, is the linchpin here. Another factor to consider when responding to the challenge of capacity is the idea of supported decision making. Now, supported decision making is a term that's used to describe a situation in which someone, usually with a intellectual or developmental disability, is supported in understanding the complexity of a decision that needs to be made, given sort of help in understanding the different nuanced factors that go into the decision. But ultimately, they are the ones with the control who make the decision, and the folks that are supporting them defer to their decision ultimately. Okay. And so I think that this is something that we all do, right? This isn't peculiar to people with intellectual and developmental disabilities, right? Recently, my van broke down, and I brought it to the specialty shop that deals with wheelchair accessible vans, and they wanted a huge sum of money to fix it. And fortunately, I had a close friend who used to work for this same specialty shop fixing these vans, and I showed him the estimate that they were wanting to charge me, and he said, "No," right? He said, "This is not a good choice. They are trying to take advantage of you here." And so he helped me figure out a alternative way to get the van fixed at a much cheaper cost. Okay, and this is, I think, an example of supported decision making. Right? We all have folks that we rely on to make certain kinds of decisions where we don't have expertise. Okay, I'm a philosopher. I know nothing about the mechanics of a minivan and a ramp and hand controls and all of this, right? Um, and so this can be an important mode of ensuring that a disabled person can maximize their capacity to make these complex decisions and control their own lives. And so what I'm arguing here is that we just need to reframe how we think about capacity, perhaps more along the lines of relational autonomy, in order to understand how it is that everyone can access what we would think of as community-based long-term care, according to my definition that I'm advancing today. The other serious challenge, and I think this is one that is serious, is what we might call the challenge of shifting oppression. Okay. And so this is a challenge that points out that perhaps my definitions of institutionalization and community-based care are too ideal. Okay. And so when doing non-ideal theory, we might say that in a non-ideal world, deinstitutionalizing care will mean not ending oppression or challenging oppression, but shifting it. Because when someone is pulled out of a institution or a nursing home or a group home and put into a more community-based setting, a lot of times the burden of care, as it's sometimes framed, will just shift onto the women in their lives, right? Multiply marginalized, unpaid, or underpaid women. Okay, and this is a problem. This happens, right? This is sort of a cost-saving measure we see when people aren't given enough support to live in a community-based, non-institutional setting, because it's just sort of presumed that the mothers and the sisters and the nieces and so on will take up the slack and fill in the gaps. Okay. Now, the problem with using this as an argument against ending institutionalization is that it is not as intersectional as we need to be. Okay, if you look at the data um, that shows who it is that's receiving long-term care, especially in institutions, you see that it is largely women, especially women of color. Okay, and so the fact of the matter is that women and women of color especially are more likely to both provide the care and receive the care. And so if we just sort of let the status quo of institutional care sort of continue, then it's also a form of intersectional oppression that disproportionately harms people according to their gender and race as well as disability, because it's women and women of color that fill some of these most harmful institutions. Okay, and so um, ultimately, I would argue in response to this challenge, which I think is legitimate, we have to be careful about how we end institutionalization. I think that we ought to emphasize, though, the politics of solidarity, because exacerbating one oppression shouldn't be seen as justifying the toleration of another oppression. And so what we need to do is have more solidarity between those that are receiving care and those that are providing care, rather than sort of pitting them against each other within how we argue about these things. So if you are convinced by my definitions of institutionalization and community-based care, then hopefully we can turn back very quickly before I wrap things up to the issue of COVID-19, because that's where we sort of started off, right? Remember, my argument was that in order to understand what our moral obligations are to people living in institutions during the pandemic, we have to better understand, the concepts of vulnerability and institutionalization themselves. Okay. And so, how does my argument here apply to this issue of the pandemic? Well, one thing that we know is that one of the most effective measures for preventing infection is what we are referring to now as social distancing. Okay. Now, social distancing doesn't mean that a person must isolate themselves physically from everyone, right? You don't just sort of lock yourself in the closet. What it means is that you are more careful in choosing who you're going to be in physical proximity with, right? You make choices about, do I go to the grocery store? Do I get my groceries delivered, right? Do I, uh, you know, um, meet up with a friend in the park with masks, or do I stay home, right? But it doesn't mean that you just never are in proximity with anyone, right? Lots of us have roommates or live with family members and so on and so forth. It just means, as you social distance, that you are really careful in weighing the risks of being in physical proximity with particular others. Okay. And so we can now see how this applies to, hopefully, we can see how this applies to my analysis of institutional versus community-based long-term care. because institutional care, by definition, takes away a person's control over who they're in physical proximity with, right? The practice of social distancing becomes impossible, not because a person needs care of an intimate kind, but because the power disparities involved in institutional care keep them from determining who provides that care. Okay? You don't have control over if you are getting care from someone who you know is going to be careful about the spread of the disease, or whether or not that person is providing care for lots and lots of other people as well, and so on and so forth. Okay, so this practice of deciding who you are in physical proximity with, and thus having the ability to social distance, just goes out the window when it comes to institutional care, by my definition of what institutional care is. And so finally, we arrive at sort of the conclusion that I've been sort of building toward, and that is that people receiving institutional care are made vulnerable to the virus because of the power structures that are embedded into the nature of institutional care, as I'm sort of reconceptualizing it. Okay. And so the moral analysis of institutional care in general, that I've worked through today, I think has revealed something important about what our moral obligations are during the pandemic to people that need long-term care. Because the same institutional care, the same features of the institutional care that make it so objectionable generally, are the same features that are posing serious health risks to people during the pandemic. And so it turns out that our duty to disabled people during the pandemic is really our duty to them anytime, and that is to provide them with community-based supports and services, by the definition that I was trying to advance. And that's my talk. Thank you for your attention.
All right, thank you, Joe. So if you all will post your questions for Joe Stramondo in the Q&A, Katie Tyner will relay those to me, and I'll pass them on to our speaker. So our first question is from Rua Williams, and she's asking, can you talk a bit about how institutions, using your definition, have also constructed heightened social isolation, for instance, no family visitation, as a part of COVID protection protocols, but that this heightens their vulnerability to the power of the institutions in the sense that the institution has walled off all access to witnesses, and that this rendering of people vulnerable to COVID has also heightened their vulnerability to abuse and neglect.
Absolutely, that's such a good point, Ro. Thank you. I think what's being referred to here is this idea that people that have others that are involved in their life, even if they are in a institutional setting, that are sort of coming in from the outside, tend to get cared for much better than if they don't have other family members and so on that are involved. Okay. In other words, when the folks that are institutionalized are being engaged with by the outside world, the institution pays attention and does a better job in terms of neglect and abuse. Now, the kinds of protocols that have been sort of the response to COVID-19 that I sort of started off with, right? Because of sort of the very limited conceptualization of what constitutes vulnerability and what constitutes institutionalization, have made it so people can't have others in their life, family members and so on, come and visit and engage with them and watch to make sure that they aren't being neglected or abused. And so if we understand institutionalization as a power structure, as something in which someone um, can control their care or not, then we see ways in which that control has been exerted during the pandemic to isolate them further, right? You don't have control over how the care is provided. And one of those ways in which you lack control if you're in an institutional setting is you don't have control over the infection control protocols that will isolate you from family and friends. And so I think that's sort of what the question is getting at here. I don't have the data in front of me to know what the effect has been as far as increases in neglect and abuse. But I do know that conceptually, this is certainly going to amplify the risk of this kind of neglect and abuse. And I also know that the nursing home lobby and other kinds of institutional providers have been very active politically in trying to protect themselves from the repercussions of this kind of neglect and abuse, right? In that there have been efforts in Congress to try to pass laws that protect institutions from lawsuits where they, because of COVID-19 and so on, are neglecting or abusing a patient, so to speak. And so I think that in and of itself shows us that there is sort of this increased risk for neglect and abuse.
Okay, next question is from Luke Beasley, who thanks you for an excellent talk. And he was wondering if you would be able to talk about how we control support services at scale. If we don't want to deinstitutionalize at the level of town, city, county, our options historically have been to use individual PA hiring, where there are lots of market pressures, which makes it difficult for people who rely on funds from the state to maintain during financial crises, or to try and gain collective control as disabled people over public support services, in which case there may be less direct individual control, but greater control by disabled people as a group. Which of these would you argue is preferable, or do you see a third way?
Yeah, I mean, I think that we're getting into the weeds a little bit with this question of the long-term care policies, I'm primarily a philosopher, and so I'm not sure that I'm the best qualified to answer this question. But I do think that the question that needs to be asked when we're thinking about the specifics of the policy is, at the end of the day, does the individual disabled person have control over their life in the way that their care is being administered? And so, do they have control over when they go to bed, when they bathe, what they have for dinner, right? Does their structure of care pass the burrito test or not? And so I think it's as simple as that. It's as simple as making the determination of what policy is going to advance a uh, a system that allows a care structure to pass the burrito test.
Okay, thank you, Joe. So our next question is from Cynthia Stark. And Cynthia asks, I think Shelley's claim that you quoted, that vulnerability to the bad effects of COVID-19 is exclusively socially determined, is too strong. Some of us are at greater risk than others of dying, having serious symptoms, or becoming a long hauler. The fact that some people are more at risk due to, for example, their age or blood pressure is completely compatible with everything you've said about the relationship between institutional power and vulnerability, including its extent, invisibility, intersectionality, etc. So why rely on the strong claim when you don't need it?
Yeah. So if you'll notice, I did quote Shelley's claim as an introduction to the idea that vulnerability is politically constructed. But in my slides, I try to soften that claim a little bit by pointing out just what you said, right? That that these two ideas are compatible. That what we need is a definition of vulnerability that includes politics in addition to physiology, rather than only focusing on physiology. And so I'm not making the same claim that Shelley is here, that all vulnerability is socially constructed. And I'm not doing that, not necessarily because I disagree with it, but because I I think it's a harder claim to defend than sort of allowing for um, the idea that some vulnerability is in fact biological and physiological, right? And so I think this weaker claim is sufficient for defending my view of what institutional care is and what vulnerability is, as far as it being political. Um, and so I'm not sort of trying to defend that stronger version. I'll leave that up to Shelley, who I think is more than capable of defending her view.
Okay, our next question is from Cecilia Munn, who also thanks you for your presentation. And she says, Joseph, I generally agree with your position on the ethics of care for disabled people and the difference between institutional care and non-institutional care. I have two questions, however. First, you note that having agency over one's care is a crucial feature of ethical non-institutional care. And although I agree, I'm still wondering if this is an over-idealization of ethical non-institutional care, especially given concerns about legal liability. It seems that concerns over legal liability drive a lot of the decisions to deny agency and institutional care. And I'm wondering how you attend to these considerations. And do you want me to give you the second half of the question or wait till you've finished answering the first?
I guess hopefully I can keep them in my head. And so go ahead and give me the
Okay,
second half of
so
the
the
question as
second
well.
question is, I'm also wondering if you draw a problematic distinction between institutional and non-institutional care, in some ways characterizing institutional care as always being unethical when compared to non-institutional care. But one can criticize institutional care and demand change without necessarily stigmatizing institutional care, as it seems you might be doing.
Yeah. Okay. So I think with regard to the first question, um, I do think that this is going to be a policy issue of trying to sort out liability concerns. In that when you give someone more control and more agency over their care, the argument will be that you have to give them what's sometimes called the dignity of risk, right? Um, and allowing um, disabled people to take risks that the rest of us, would also take if you don't have, in particular, some kind of intellectual or developmental disability in particular. Um, now, um, I think that uh, this does pose an issue when it comes to liability, because if you give someone the dignity of risk, does that mean that you are then absolved of responsibility if things go wrong, right? Um, and so, I think that this is where something along the lines of supported decision making can come into play, where giving someone control over their care doesn't mean just throwing them to the wolves, but rather supporting them in making the best decisions that they can make for their own care, in very complex situations. In other words, making sure that there are people that they trust that are helping them understand all of the nuances of various decisions that might be involved in their care. But at the end of the day, ensuring that whatever decisions are made are their decisions, and that they are in a situation where they can pass the burrito test, so to speak. Um, so I think when it comes to something like um, liability, that there is a balance that can be struck, where people are um, able to uh, still control their care um, without saying that the caregivers are absolved from any kind of repercussions if things go wrong. Um, Now, in terms of the second question of stigmatizing um, institutional care, now that's a tough one. I am I'm inclined to say that I'm okay with stigmatizing institutional care. I'm inclined honestly to say that that stigma is is a bad thing in most cases, but when it comes to some kinds of very morally pernicious, as the title of my talk claims, when it comes to some very morally pernicious systems, that stigmatization might be a perfectly appropriate thing to do, and that I might be all for um, ending institutionalization as I'm sort of describing it, as a form of control over people's lives, um, and that some things ought to be uh, regarded as morally problematic always. Um, so yeah, I can bite that bullet, I think.
Okay. Joe, we've only got 2 minutes left, but I'll read one last question because it's a short one. This is from Melinda Hall, and she asks, does your argument apply to incarceration? And if so, how?
Good. Wow. Wow. Yeah. No. Good. Um, so, does my argument apply to incarceration, as far as whether or not it ought to be understood as a form of institutionalization? Um, I think it does. I think that it does apply to incarceration, in terms of incarceration um, absolutely entails the kinds of lack of control that I'm talking about when thinking about what defines an institution. Now, I think the difference is arguments about whether or not um, incarceration um, gives uh, different justifications for that control being exerted, right? Um, Whether or not it's justified in terms of punishment and incarceration, but not justified in terms of disability, I think is kind of an open question, according to my argument. I'm not willing to say that incarceration is a good thing, and that's it's completely different, and that it's always justified, whereas congregate care of disabled people is never justified or something, right? But I will say that adds a wrinkle of complexity to the issue that I think is sort of beyond the scope of what I'm arguing here, and that it deserves more exploration. Right? Are both forms of institutionalization? Yes. Can both be morally problematic? Yeah. Um, can one be justified and not the other? I don't know. Maybe, maybe not.
Okay, I think we'll wrap up there because we're out of time. Thank you so much, Joe, for a great talk, and to everyone for fantastic questions.
Okay, so thanks so much, Laura, for sharing, and Joe for a really fantastic talk, which I was partially live tweeting as you were doing. I was so impressed with what you're doing. So one of your slides is now all over Twitter. I hope that's okay.
Very cool. Thank you, Joe.
Yeah.
Thank you for the opportunity, Joe and Shelley.
Okay, great. Well, thank you both, and thank you to everyone for the excellent questions.